Uh, so I'm afraid I can't answer this question.
This is this can be like a different.
No, 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 no.
होता ना अंग्रेज भी चला गया बोला यही बोलेगा हमारी तरफ से और वो शुरू हो जाता है टू द हेडमास्टर आई बैक ग्रुप से
तो पूर्णिमा भी इंटरेक्ट बस हर तरफ से अपने बोलना अनिल शर्मा और अनिल धुल
Hi everyone, welcome all. We are about to begin the panel discussion on rare tumors of endocrine origin. First of all, good morning, good afternoon, and good evening in whatever part of the world you are, and we welcome you all. So, can I introduce the panelist? This is Dr. Anil Dhol. He's a radiation oncologist from Rohtak. And to my right is Dr. Anil Sharma. He's an endocrinologist from Jammu. Can I have the first slide? Next one. Myself, I've already introduced myself. I'm Dr. Aman Sharma from IGMC Shimla. I'm a radiation oncologist. So my first question would be, what do you mean by endocrine tumors, and where do they originate from? Maybe Dr. Anil Sharma can answer this question for our live presentation.
Thank you very much. The endocrine tumors are the tumors of the endocrine glands. You know, there are various endocrine glands in the body like pituitary, thyroid, adrenals, some endocrine present also in the gonads. So any tumor arising from a endocrine gland is called endocrine tumor.
Yes, very rightly mentioned. And the endocrine system is a system that is responsible for secreting some kind of neurotransmitters, which we call hormones. So first, we'll talk about pituitary gland. It's located in the base of skull, and it controls different organs by secreting different neurotransmitters, which we'll later. Then is the adrenal gland. The adrenal gland is situated just above the kidneys on the upper pole, and the pancreas is situated in the abdomen. It's a retroperitoneal structure. The parathyroid glands, pair of glands that is situated in the neck, in the thyroid region. So most of the tumors arise probably from these glands. Of these, the most common is the thyroid cancer, and it is the most common endocrine system malignancy. It is on the rise, likely because of widespread use of studies. It is the most common thyroid malignancy is papillary carcinoma. The important thing is that it is the least aggressive one. And with good treatment, I think Dr. Anil Dhul would agree with me that we can reach survival.
Yeah, I personally feel that the 5-year survival is more than 90%.
Yeah, for our viewers, Dr. Anil, can you tell us how do we suspect thyroid cancer in an individual, and what are the warning signs? How can we help the normal people to get aware with this kind of disease?
Yeah, Dr. Aman, we have to see the most common sign and symptoms in the patient, like any lump in the neck or hoarseness of the voice. These are the most two common, and accordingly, we have to detect that the nodules which are there, detect the nodules which are detected. In majority of the cases, they are benign type, not the malignant. Malignant are quite rare. The benign are the very common type of nodules, and we have to further diagnose that what is the type of nodule it is by various other diagnostic tools.
Yeah, I think very rightly said. It's important to know that we can have a small palpable nodule in the anterior part of the neck. So whenever you develop a nodule, probably you need to consult a doctor. Sorry. Important thing is that most of the nodules are benign, and it's only 5% or less nodules that are likely to be malignant. However, it is important that once you develop a nodule or you see a nodule or you're palpating your neck and you come across a small nodule, it's always good to consult a doctor, and especially the nodules when they are more than 1 centimeter, they are to be uh, evaluated. Of course, along with the thyroid nodule, as the mass grows, there can be like difficulty in swallowing, difficulty in breathing. There can be change in voice, but all those are very advanced symptoms. The most important is probably when we have a small nodule, you need to be careful with that. You need to consult your doctor, and you don't have to panic as well, because most of them are benign, and it's only so if you have a small nodule, there are 95% chances that you're not having a cancer. But it's also important to consult your doctor, because there are 5% chances that you may still get a cancer. And detecting early is also very important. And we know that probably the survival is more than 95% for the most common histology. So you can keep those things in mind.
Patient should be advised to be calm.
Yeah, that's very important, because most of the thyroid cancers are benign. Swellings are benign.
So most of the nodules are benign, and even if it is found to be cancer, the survival again is very good. So there is no need to panic as per thyroid cancer or concerned. I think most of got a very good prognosis in thyroid cancer.
Yeah, and what are the type of thyroid nodules or cancers? What are the type of cancers that we can normally have? Maybe Dr. Anil Sharma can take this question.
So thyroid gland, basically you can have either epithelial or non-epithelial. You can divide mainly two. Then there are the rarer types. Sometimes you can have from some neuroendocrine tissues like medullary thyroid carcinoma. And rarely you may have poorly differentiated what you call anaplastic tumors. But the most common papillary or follicular variants of thyroid. Sometimes you may have only have adenoma, which will not be malignant.
Yeah, very rightly said that the tumors can arise from the epithelial tissue, and they can arise from the non-epithelial tissues. Again, I'm repeating that most of them are likely to be benign. They are likely to be adenomas, so you don't have to worry. You're not suffering from cancer per se. Regarding the malignant part, probably only 5% of these nodules will turn to be malignant. And the most common, of course, is the papillary carcinoma. Then you can have a follicular carcinoma. Then these probably the prognosis or the survival is best for the papillary carcinomas. It is good for follicular, but it can be worse for the poorly differentiated carcinomas or the anaplastic carcinomas. Only thing is, uh, fortunately, the undifferentiated and the poorly differentiated are rare, though aggressive, but they are very rare. Also, another can I have next slide, please? Important thing is that when we are treating papillary carcinoma or follicular carcinomas, which can be like can turn into polydifferentiated and anaplastic carcinomas, like they can have transformation. So when we are treating a malignant thyroid nodule, which is a papillary carcinoma or a thyroid carcinoma, the goal of treatment is not only cure, but it's also preventing the transformation of these carcinomas into poorly differentiated or anaplastic, which have a poor survival. I hope, Dr. Anil, you would agree with me on this.
You're perfectly right.
Okay. Can we go to the next slide, please? We are discussing a bit, but we have known that the symptoms most common is the lump. The lump most of the times would be benign, but how can we detect them further? Dr. Anil, can you?
Yeah, basically, we have to first of all do the thyroid function test, which
Yeah.
is the most important.
Just give a short details so that it's not too much for our viewers, because not all of them would be from oncology. So just a brief overview.
Yeah, thyroid functions, and then radioiodine scan, then the sonography of the neck, and FNAC of the that particular nodule, which is the most important in diagnosing the cytology of the that particular nodule.
Yeah, it's very rightly said. Probably of all these investigations, the fine needle aspiration biopsy is the most important. Here we draw material from the thyroid nodule and we further study it to see the subtype, whether it is benign, whether it is malignant, and if it is malignant, is it a papillary carcinoma, is it a follicular carcinoma, is it undifferentiated carcinoma, or it is a
FNSC also sometimes, if it is better, sometimes you can go for ultrasound guidance because you can pick up the area, and but from the particular area, the yield will be better.
Yeah, of course, absolutely. So this is just a brief overview. Can we have the next slide, please? So, what would be the treatment options for a thyroid cancer? Just an overview for our viewers who are not oncologists. Just an overview, like how do we treat the thyroid cancer? Suppose it's FNAC is positive, say it's a favorable type, maybe it's, you would say papillary or follicular, because these are the most common types. So, what do we do once
So
the patient
once
is,
you have,
and we have staged the patient according to the size? What are the treatment options?
once you are diagnosed the patient with the thyroid cancer, say papillary or follicular, the first thing you want to tell the patient is the prognosis is very good, so there is no need to panic. The treatment options are: number one is you have to remove the thyroid gland. That is called thyroid. That is surgical cure. That is thyroidectomy. Most of the time, what you go for is a total, complete thyroidectomy. But some people are now for also advising a limited or lobar on partial thyroidectomy for a small non-invasive lesions. After you remove the thyroid gland, then you have to follow up this patient with the radioactive iodine scan, find out if there are any residual tumors or any spread there, and then you can go for a radioiodine ablative therapy afterwards if they require. Most of the people may not require a radioiodine ablative therapy after the removal of the, because as many people surgery can be curative almost.
Yeah, very rightly said. So probably we need to excise, do a surgery that is not for the benign lesions. We need to do a radical surgery, and probably we need to address the neck as well. What amount of tissue is we can dissect if whole of the thyroid is to be taken out. If the tumor is small, we can probably lessen the extent of the surgery. Of course, a little bit of thyroid tissue can be left, and we have to save the parathyroid glands as well. So a small amount of tissue can be left there. So then we need to do this radioiodine scan to see what amount of tissue is left, and then accordingly we can ablate if it's a non-metastatic. Also important is that even if it's a metastatic and even it's a papillary carcinoma, still you stand a very good chance of cure. So another important thing to remember is even if it's a metastatic papillary carcinoma thyroid, you still have a good chance of cure. Also, it depends upon the age, of course. If it's a metastatic, of course, the other options can be tyrosine kinase inhibitors, and of course, depending upon some very adverse features, and if there's multiple recurrences, some extra capsule extension, you can select the patient early to external. So the crux is most important is that uh, most of the lesions will be benign, so you don't have to panic. Even if it's a malignant, probably 70 to 80% chances are there that you will have a favorable histology, which is a papillary or a follicular type. And even in a stage 4 papillary, it's curable. Only the unfavorable histology is poorly differentiated, and the unfavorable histologies, they have a worse prognosis. But fortunately, these are rare. And the next slide, please. So I think then we move on to the second pituitary tumor, which is the second most common malignancy affecting the endocrine tumors. So Again, we can see that in this also it's the pituitary cancer is very rare. It's probably the pituitary adenoma. These are the benign, but of course they can be troublesome, which we will discuss. Important thing is that they are not very uncommon, and probably 10 to 15% of the all lesions in the brain are benign pituitary, can be benign pituitary adenomas. Can we have the next slide? So just how can we classify pituitary tumors? Of course, we know that the carcinomas are very rare, so we would not probably go in that. It's important to discuss pituitary adenomas. So how do we classify pituitary adenomas? Maybe Dr. Anil Thul can take the question.
Yeah, basically they are categorized based on that what is the primary cell of origin of the adenoma, and what is the hormones secreted. These are the things that helps in the further differentiation, and uh, but whether it is a functioning type or non-functioning type, these are the criteria which helps in the differentiation of the adenomas. Further, they can be based on the what is the size, whether it is a macroadenoma or microadenoma. We can further differentiate basis on the scans of those particular adenomas.
I think we have Dr. Purnima from US as well connecting us to us. Welcome, Dr. Purnima. Hope our voice is very clear to you, and we are
It
quite
is.
audible to you.
Yeah, I can hear you just fine.
Okay. Thanks a lot for joining us as well. Would you also classify this pituitary tumor based upon the size as well?
Yeah, but I don't tend to see them very much. Maybe it's a bit of a pediatric, or they don't come to they don't get to me usually because I'm a medical oncologist. So I have not seen until this is a neuroendocrine or something like that. I wouldn't see. I have not seen any much of those. And even thyroid cancers, for that matter, until I've treated a few anaplastic, that's horrible. I know, but other than that, the regular types they don't come as far as to us.
Okay. Thanks for answering that. Maybe we can go back to the thyroid cancer, and maybe you can give our viewers a little bit details about the targeted therapies that are available in thyroid cancer. When do you use them? Because now we have a dedicated medical oncologist with us, so probably you can throw a light in this area.
So so that's the thing about systemic therapy for thyroid cancer. When do we use it? In mostly metastatic settings, and of course, if the volume of the disease is quite a bit, particularly like pulmonary involvement and everything, I tend to use Abraxane-based chemotherapy usually. However, more lately, I have used the TKIs, of course, with I would not say that I'm very impressed with the responses, so to speak. The cancers that I've seen that come to us after all that is done at the ENT and the endocrinologist, they're usually very aggressive. So I've not seen a whole lot of stability with TKI, but maybe about 6 months to 1 year at the most we have used this for.
Yeah, I think that's a very honest answer. I would say probably when the tumor becomes refractory to everything, and that's when the people are consulting a medical oncologist, if I'm not mistaken, and there would be a huge amount of selection bias that probably you're receiving one of the worst candidates who are not responsive for all the treatment therapies, and those are probably the bad subtypes, or maybe they are starting to show some signs of transformation and responsive. So do
I
you
probably have more experience treating anaplastic thyroid, which is such a rare thing, as compared with treating the follicular or papillary. Can you believe that? I mean, all the patients I can remember right now are having anaplastic growing, and do what you want to do, but you can't stop that kind of a thing. So the most effective has been Abraxane, but nothing beyond that.
Okay, so in your clinic, when you treat anaplastic carcinoma, do you treat it upfront if metastatic, or do the patients are referred once they receive radical concurrent chemoradiation, or do you normally get transformed cases more, or they are de
No,
novo?
de novo anaplastic mostly, and they have usually they're upfront, and some of, I mean, again, and with the upfront treatment also they progress quite rapidly. I don't remember of any anaplastic thyroid carcinoma that I can remember at this point of time who has remained stable for 1 year, and I can say, well, we have even gotten some durable response on that. No, I did not have any such thing. Now, I don't know what's going to happen with our immunotherapy. I think that might be the place to go actually with these things.
Yeah, I also feel that, because given the limited options and of course such an aggressive and fatal course, maybe immunotherapy can show some light probably at the end of the tunnel. So I think it's very nice to have your thoughts. And we can continue on pituitary tumors. So yes, as Dr. Anil told, we can classify the pituitary tumors according to the primary cell origin. It means that what type of hormone is it secreting. We'll discuss that in detail. And of course, we can see whether it's functioning or not functioning. So functioning tumor normally it secretes hormones. And when the hormones are secreted in the blood, they are secreted excessively. And these hormones produce symptoms, which we'll discuss in detail. A non-functioning is probably diagnosed a bit late, probably because it's not secreting anything. So it grows big in size. So another criteria according to which we can diagnose them is the size. So if it's less than 1 centimeter, we call it a microadenoma. If it's more than 1 centimeter, then we call it macroadenoma. Can I have the next slide, please? Next slide. So yes, we can see that the first one is a macroadenoma. The red pointer is showing it. It's a big size. It's causing compressive symptoms. And another is a microadenoma, is less than 1 centimeter. So in clinical practice, it's that microadenomas are slightly more common than the macroadenomas. One of the reasons, of course, can be that they are detected early because they produce symptoms. So maybe Dr. Anil Sharma can take the questions. What all symptoms can a pituitary tumor present? A patient with a pituitary tumor present to us?
Pituitary tumors basically, pituitary is a master gland of it. It secretes most of the hormones. If it is pituitary tumor, then the symptoms will depend upon the type of hypersecretion you get. Most of the time, there is a single hormone hypersecretion, like you got a growth hormone or ACTH or TSH, or more commonly hypersecretion is what sees with growth hormone and ACTH. But most common pituitary tumor what you get is actually prolactinoma. Prolactinoma basically is either micro or macroprolactinoma, most common pituitary tumor. That is because of there is an inhibitory effect of the hypothalamus in the pituitary. Symptoms will depend upon the type of hormone oversecretion. Sometimes you may have a multiple hormone secretion excess. Sometimes you may have growth hormone and prolactin secretion excess.
Yeah, I think very rightly said. So the symptoms would depend upon the type of hormone produced. And of course, when they are producing hormone, they can also have some systemic effects of these hormones. You can have sugar, you can have diabetes, you can have skin changes, you can have bone, which will weaken your bone. We'll see that later. Of course, for the non-functioning, it's important that they are normally detected when the size is more. I think Dr. Anil would agree with me. And when they are macroadenomas, like it's situated in the base of skull. So when this tumor starts growing, there's a visual pathway just going above the pituitary gland. What happens is when this macroadenoma grows in big size, it's kind of compresses the optic chiasm. It's a visual pathway, I would say, for the viewers. So it produces some changes in the vision, which can be detected. So if you're having some kind of visual changes, it's not always that you need spectacles or some other things. You can also suspect that maybe there could be something that's compressing your optic pathway, and sometimes it can be pituitary adenoma.
So that's going to be a very rare possibility.
Yeah, of course.
But we should keep in mind as a clinician.
Yeah, definitely. I do agree with you. So, what are the most common type of pituitary tumors, and what would be their frequency? Maybe Dr. Anil can throw us some light into this area.
These can be broadly divided in non-functioning adenomas, or growth hormone secreting adenomas, or these can be prolactinomas, or they can be ACTH secreting adenomas. So these are in my view, these are the broad classification of different adenomas.
Yeah, very rightly said, and as also pointed.
I think prolactinoma is on the highest side, that they are having the higher incidence out of all.
Yeah, as told by our esteemed panelists, I do agree with them that prolactinoma is the most common, and it counts for nearly half of the pituitary tumors. Then are the non-functioning adenomas, then is the growth hormone secreting adenoma, and then is the ACTH secreting adenomas. Can you have the next slide, please? Of course, Dr. Anil Sharma can throw some light on what are the presenting signs and symptoms for
So the prolactinomas are the most common pituitary tumors, especially in the reproductive age group. So many people come with the problems of infertility, irregular cycles, and sometimes they can have galactorrhea, and so irregular cycle, galactorrhea, and so these are the common symptoms what they present. And so once you have these symptoms, then you investigate them, and many people will have prolactin levels in their blood. Once you increase prolactin, then you find out cause of increased prolactin, whether it's a pituitary tumor or some other cause of increased prolactin. Because many drugs can cause also, like increased prolactin level. When you get these patients of hyperprolactinemia, symptoms of hyperprolactinemia, so you have to first think what are other causes of increased prolactin. Many commonly used drugs like you use for having this domperidone and other and antipsychotic drugs, then they can also raise prolactin. Even stress can raise prolactin. So there are various causes. Once you exclude those, then you go for the investigation of the prolactinomas, and those who are not in the reproductive age group, they can present with the osteoporosis, weakness of bones and other things. And if it is micro, they don't have usually CNS symptoms. But if it is macroprolactinoma or a tumor is large, then they may have headaches or visual disturbances. But most of the time, because this occurs in a younger age group, the symptoms come before they have got these pressure symptoms. And macroprolactinomas are rare, and microprolactinomas are more common in the practice.
Yes, I think very rightly said that once we are having these symptoms of hypersecretion of the prolactin hormone, there can be a lot of reasons. And as rightly pointed out by Dr. Sharma, that we have to evaluate what are the causes, why is my prolactin increasing. So there's a battery of investigations that we need to do. Of course, we also do a MRI scan of the brain, and if we find a tumor there, then probably we know the cause of hyperprolactin, prolactinoma. But if there's no tumor, probably then it's uh, and it's not the pituitary gland that is responsible. Next slide. So, of course, the goal of the treatment is to restore the normal gonadal fertility and also to reduce the size in case it's a macroadenoma. So, what are the normal treatment options, and what is the preferred treatment option? Maybe Dr. Anil Dhul can take that.
Yeah, normally the practice is to give the tablet cabergoline, which is quite effective in these type of patients, and a very good response with cabergoline is observed in the literature. And we can also, if the patients are not responding to cabergoline, we can consider for the surgery or radiotherapy if it is not responding to any of the two regimes, like stated before, like cabergoline or surgery.
Dr. Purnima, are the medical oncologists also treating prolactinoma, or it's always the endocrinologist in US that's treating?
Yeah, no, I haven't seen any prolactinoma. I mean, I know some young women who have it, but I don't treat those. Sorry.
Okay, so probably it's always the endocrinologist that is primarily responsible for the treatment, and once it is refractory, probably then he consults a surgeon, and if those don't work, then probably it's the radiation oncologist that's consulted.
The
But
stereotactic
of course,
radiosurgery,
what
right? I think they
that
can do a stereotactic radiosurgery for that area, isn't it? Like a cyber.
yeah, I think it's yeah, that's a very good point. The only drawback of radiotherapy is that there's a long gap between the hormone and normalization. So with the external beam,
Okay.
probably it could take years for the hormones to normalize. Of course, with the stereotactic, as you mentioned, the time period would be less. So maybe it's for 5 years in external beam, so it could be like 2-3 years for radiotherapy with the SBRT or SRS. But
Yeah.
of course, we know that the first choice is always medical, then it's surgical or radiation. Can you have the
Thank you.
next one? Uh, Dr. Anil Sharma, can you please tell us, the viewers, something about the next secreting tumor, that is the growth hormone secreting tumor? What would be the normal sign and symptom
So
that we
after
can expect?
prolactinoma, the growth hormone secreting tumors are the most common pituitary tumors. The problem with GI secreting tumors is that because the effects of GI are very slow, because they leads to increase in growth. Sometimes you get a prepubertal tumor, so you want them, and what you get is the increase in height. So they are very rare. Most of the time they present post-pubertal, and post-pubertal actually they are picked up sometimes only by they come to doctors for some other problem, and you see them, then you find that they have got features of acromegaly because of increased acral growth and because of increased soft tissue growth and some other features. So they're very slow growing tumors, and many of times these people don't know that they have got problem, and many times they present with the complications of excess growth hormone for a very long standing year, like 10-15 years, they might have problems. So unless this some people develop only pressure symptoms, they will have visual disturbances, headaches, and then they will present to you, and then you will see them that they got a pituitary tumor. And many people have presented with like hypertension, diabetes. Even I have seen people presenting with hypertension, even going into congestive cardiac failure first time, and then you find that patient got a features of acromegaly because these changes are very slow growing, so they are not recognized. So they can be recognized by some people, those who see them after 4 or 5 years, because those who are living with them, their siblings or friends, they will not recognize. So the such a slow growing changes are not usually seen. So this requires a lot of awareness, and sometimes you have to see the old photographs or the old photographs. Subtle changes like change in shoe size, change in head size may sometimes prompt you for this diagnosis. Sometimes the increased growth of the fingers or feet size. So the symptoms are very subtle and very mild, but once they develop complications, then they develop symptoms like diabetes, hypertension, increase this cardiovascular morbidity and mortality. So those are the problems what they face, and sometimes they can come to you with a spine problem. So GH are mostly presenting with the complications of excess growth hormone for a very long period of time, and many people are diagnosed late. And even if you find a patient who has got acromegaly feature, you tell him that you got this problem, so they are not aware and they may not agree for further investigation many times. So that's the problem also. So it's actually usually diagnosed very late. Breast access are diagnosed quite late because people don't present; they present only with complications. That's the problem.
Yeah, I think very rightly. So we also need a very high level of suspicion, especially a person with we cannot of course screen all the diabetes and the hypertension patients for growth hormone secreting tumors. But of course there can be some guidelines, some tips. A patient who's growing very fast or who has features of gigantism or has some features of acromegaly, and you notice that, and he comes to you in a clinic for a diabetes and hypertension. Of course you can always go in and evaluate the growth hormone tumor. uh, how I remember a growth hormone secreting tumor patient is, I think, important, and maybe it will help you all as well. Maybe Dr. Dhul can tell us about some personality who has a growth hormone secreting tumor, so that all of us can remember it and remember it very vividly, and all the viewers also can remember it.
Yeah, Khali is one of the very good example of gigantism, and Even in the historical examples are also there. You'll find Titan and Helios, as mentioned in the literature. Helios, which was killed by David. So these are some of the examples which I remember that they are the ideal examples for preventive.
Yeah, and they also say about Khali that probably once he is very tall, he has a broad jaw, he has broad hands, broad feet, and he has weak bones. And they say that one of the reasons he could not reach the top was because uh, he had weak muscles, and once he fell down, probably he could not rise up, all because attributed to the excess of growth hormone. So maybe Khali is one of the examples we can always remember. So any patient who is growing very tall, maybe reaching 6'5", 7", or otherwise the one who has long and flat bones, jaw bones is increasing in size. So all those features can give a bit of idea about the patient is suffering growth hormone. Of course, we need to create awareness for this, as Dr. Anil said. That these tumors are diagnosed very late, and by that time probably they have experienced a lot of growth hormone changes brought about by the hypersecretion. Can you have the next slide?
I apologize, Dr. Sharma, that Goliath is one of the example that I've given two examples, but Goliath is one of the example that I was mentioning at that particular time. Yeah.
So, how can we establish the diagnosis of a growth hormone secreting tumor? Maybe Dr. Anil Sharma can give his expert comments on that, because it's important and it's diagnosed late.
For diagnosis of growth hormone hypersecretion, you have to demonstrate a hypersecreting growth hormone levels. Because growth hormone levels are fluctuating always. So what you do is you go for the oral glucose tolerance test. By giving a glucose, you try to suppress the levels, and if after suppression also levels are higher, that means you are suspecting a excess growth hormone secretion. And once you have oral GTD, the oral GTD like any other GTD which you do in a diabetic patient, you give a glucose and then you do sampling of glucose and growth hormone every half an hour for 2 hours, and then there are cutoff values, and if the cutoff values are beyond that, then you suspect a excess growth hormone secretion. IGF-1 levels also are increased. So IGF is one of the mediators of growth hormone action. So you can have a IGF. Once you have a demonstrated increased GH excess and IGF-1, then you try to find out the source of this hypersecretion. And for that, the most common area is the pituitary. Then you can go for scanning or this procedure in the blood. Like MRI is the most sensitive to find out any pituitary tumors. And there, most commonly, what you find will be in the pituitary. But sometimes you may have some other tumors like ectopic secretion may also be there. So in those situations, then you have to if you have those situations, then you have to go for scanning for other areas like if there is a GHRS secreting tumors from some other areas. So that also then they are very rare. But most of the first thing you will do is MRI of the brain.
I think that's very well said. Of course, we need to do some glucose tolerance test, IGF-1 test, MRI of the brain. Of course, we are running short of time, so we'll quickly go through the treatment part. Can you have the next slide? Of course, apart from this, these patients are have increased chances of colon cancer, cardiac valvular disease, disturbances in sleep, and of course, they can have thyroid nodules and thyroid cancer. Next slide, please. Next slide, please. Of course, we know that the goal of treatment is to reduce the growth hormone levels, and the preferred treatment in this case is surgery, a transcranial approach. Then we have some medical therapy, and the radiation is reserved once the surgical therapy or the oral treatment fails. Then we move on to the next one, please. Uh, I think we can skip this in view of time. We'll just briefly overview the non-functioning tumors. So, Dr. Purnima, can you take that? How do you diagnose the non-functioning tumors if you are treating any at your clinic? And what treatment options are available at your end? In case you can take in general as well, and you can tell us something about.
That sounds like my MBBS question. I have no. I'm sorry to say, I do mostly breast cancer, leukemia, lymphoma, and BMTs. I've not seen too many of non-functional tumors, but common sense being there, if there's any pressure symptoms, of course, of neurologic, obviously we'll proceed with a cranial radiographic evaluation. And based upon what we see, again, of course, as the previous speakers mentioned, we will do the functioning tests, essentially, of the growth hormone and other hormones, and as well as their parent hormone, to check if there's a feedback loop is functioning or there's autonomous secretion of these hormones. Now, if they're non-secretory and they're basically a nuisance of no value, then take it out. That's what I would think should be done, until unless that place, the location is such that we cannot do that. So how to take it out? That's up to the surgeon, how they get their transpenial, or transnasal or whatever. And if not, then we call the zappers, what you call the radiation people, to come and
I think very rightly said. Of course, for the non-functioning, the important thing is that they're not secreting any hormones, so there are no systemic effects. The patient do not have any valvular disease, they do not have diabetes, they do not have hypertension, they do not have weak bones, they do not have muscle weakness. So this is a different subset from the secreting tumors. The only thing that worries is the loss of vision, and when they have the compressive symptoms, as rightly told by Dr. Purnima. So of course we can go ahead with surgery. Of course there are some centers, and when you find it difficult, you can also go with radiation. Radiation again can be of two types. It can be a long course radiation, which we call external beam radiation or conformal treatment, and another, as Dr. Purnima can be a stereotactic radiation, that can be SRS. So if it's not very, very close to the optic chiasm and we can spare the optic chiasm, probably SRS or SBRT or fractionated SBRT is a better option because of the short treatment time, and it can reduce regression of the tumor more quickly than the external beam. It's very close to the optic chiasm, probably then there are chances that you can injure the optic chiasm, and then probably we can go with a more fractionated course of radiation. I think we have just 2-3 minutes left, so we can just discuss a bit about pancreatic tumors. Maybe I'll shortly put you to Dr. Purnima. How you treat pancreatic tumors?
So I know pancreas, okay, so that's my zone. So, but again, I'll go to directly the pancreatic adenocarcinoma. So essentially, obviously the non-endocrine type. Now the endocrine pancreatic tumors, I think that's what you're trying, because this is the endocrine panel. So the glucagonema, or insulinomas, they're symptoms essentially, right? And how do you treat? They don't come to, once again, sorry, they don't come to me, and I've never really treated them. I suppose you guys take care of them very well before, so I've never seen those. I've seen tons of pancreatic adenocarcinoma. We can talk about that if you want.
Yeah, you can just walk our viewers briefly about the pancreatic adenocarcinomas as well, like what symptoms do they produce?
It's a horrible disease. In the last 15 years, I have been a medical oncologist. I have seen at least, I'll say, a good 200% increase in the incidence of pancreatic cancer. I do not know what is happening. I have a big suspicion it's our food and our, they say the lining of the canned foods, etc. These are all carcinogens, and it's a horrible tumor. I think I'm most afraid of the pancreatic cancers. Of course, the thing is they're fast growing, they're staging, and how are they found? One thing I've seen usually particularly in certain parts of this country, if someone comes up with diabetes all of a sudden, and there's no reason, this is not a big chubby person or anything like that, I have seen association between diabetes and the incidence of pancreatic adenocarcinoma. That could be the exocrine endocrine function both being affected by a tumor. But that, again, every diabetic, you cannot be checking them for pancreatic cancer. So symptoms, typically they'll be obstructive symptoms. That's how they present. They're yellow in color. They'll have bile duct obstruction. You'll do an imaging study of some nature and you'll find out what's happening. If it is less than 3 centimeters or so, then you can, and localized to pancreas, then go for the surgeon, go for the knife. However, if there's any involvement of the celiac plexus, the superior mesenteric vein, superior mesenteric artery, or anything of that nature, then it becomes a T3 tumor. It can be surgically removed later on, but not right now. So you have to go with the pre-operative or neoadjuvant chemoradiation therapy. That's what we do a lot here. Different protocols, different regimens, but that's one thing. Unfortunately, the biggest problem with pancreatic adenocarcinoma is the rate of rapid metastasis, and that we must keep in mind. We used to get a lot of Whipple's procedures, the big, huge 14-hour surgery. By the time people recover from that, they never come to us, they never get systemic therapy, and we used to lose patients. So now we are very much into giving pre-operative chemoradiation therapy and followed by surgery, followed by adjuvant therapy.
Yeah, I think very rightly pointed out. The symptoms for adenocarcinoma of the pancreas would depend upon this location. If it's in the head, probably yes, you would have obstructive symptoms. If in the body, if it's the big tumor, yes. In the tail, of course, it's a very rare, but that'll produce symptoms a bit late. As rightly pointed out, the primary treatment is surgery. Despite everything, I think the prognosis is very poor, as already discussed by Dr. Purnima, and they can be classified into operable, borderline resectable, and unresectable. For borderline resectable tumors, of course, as we can go in for preoperative neoadjuvant chemoradiotherapy. Some centers are also going for SBRT, and if they see the tumor is showing some response, then they go in for resection. But of course, the overall prognosis is great, and they are very difficult tumors to treat, but they are not very common. With this, I thank Dr. Anil Dhul, Dr. Anil Sharma, and Dr. Purnima for joining me in this session. I hope you enjoyed it. Have a nice evening. Thank you.
Thank you so much for having me.